This is Dr. Tawari.
And this is Dr. Kochak.
And you're listening to the
Best podcast ever.
Broadcasting from Columbus, Ohio, we'll be talking about plastic surgery procedures focusing on only the breast.
Ranging from breast reconstruction to breast enhancement and reduction, we'll cover everything you ever wanted to know about the breast.
Welcome to the Best Podcast Ever. We are very, very excited today to have Clay Roush, who is probably the single biggest reason for why we've been able to do some of the more complicated cases in the outpatient arena. So Clay's going to talk to us about all the magic that he does and what's changed versus these cases in the hospital. So Clay, why don't you start by just kind of telling folks a little bit about yourself?
Thanks for having me on. I really appreciate it. My name's Clay. I'm a CRNA. I've been in practice since 2015. I'm originally from West Virginia. I trained doing my anesthesia in Florida, and I've been in Ohio since 2016. And
hey, Clay, maybe give people an idea. What is a CRNA? I don't know if everyone's familiar with that terminology.
Sure. So CRNA stands for a Certified Registered Nurse Anesthetist. Actually, we're in some processes of going through some name changes as well. So that's maybe something that's up and coming, but it might be referred to as a nurse anesthesiologist to keep some of the confusion down in some of the patients in the operating room. But anywho, a CRNA is somebody that has their bachelor's degree in nursing, has a minimum of 2 years critical care training or ICU experience, and then they go back for about another 3 years of anesthesia training, specialize in anesthesia. And it is confusing. There's multiple different anesthesia providers in operating rooms across the country. Different facilities choose to elect what type of providers they're using and different rationales for it. But yeah, that's basically it in a nutshell.
Cool. We've got Dr. Colley on the phone here too. He's calling in, so he'll probably jump in with a few questions, I'm sure.
Sure.
But Clay, give me an idea why you think we're able to do some of these more complicated cases in the outpatient arena, whereas before we started working with you, it really wasn't something that we thought was possible.
Sure. Well, I don't think it's a big surprise that the opioids that we utilize in the operating room in most facilities is a big problem. I think doing this opioid-free anesthesia allows our patients to be up, moving, ambulating, and feeling better much sooner. Therefore, it makes things in the outpatient world a lot more reasonable to do. I would say that that's probably the biggest component. Other than that, I would say that if you tag the regional anesthesia or what we refer to as nerve blocks in that mix, it gives the patients an extra 24 to 48 hours worth of pain control that they didn't have previously. And that's probably a big step in them being able to do these procedures outpatient.
Yeah, you're probably one of the most common questions we get among patients is what type of anesthetic are you using? It's always a hard question for me to answer because, one, I'm not an anesthesiologist, but I'm not even sure how patients are thinking of types of anesthesia. You know, I don't think they're looking for the name of the anesthetic.
Sure. So it's also somewhat complicated in terms of the anesthesia providers as well, because we're so trained to do everything and document everything in terms of a billing standpoint that essentially we have three main categories when we're talking about anesthesia in the anesthesia world of billing. And one would be considered general anesthesia. And general anesthesia would qualify as essentially any form of sedation where you would lose what we call your airway reflexes, which essentially means that there would be some airway intervention, either through an endotracheal tube or an LMA. Both of those would categorize in the realm of general anesthesia.
So if you're intubated, i.e. you've got some kind of tube down your throat, that's a general anesthetic.
For sure. Now, when you can go a little further in those, and sometimes we'll document something as what we call a TIVA, which stands for total IV anesthesia, because general anesthesia can be delivered by both airway gases, the inhalational agents that we use, and then it can also be given through the IV. So that's a subcategory of general, but still considered general anesthesia. The other category would be considered what we call MAC, which stands for monitored anesthesia care. Big fancy word, basically just meaning that you're getting some sedation and you have an anesthesia provider at your bedside with you every minute of the way.
Okay, and then the third category?
The third category would fall into more of the obstetrics and epidurals and spinals for labor and delivery and different things like that, and regional anesthesia. Usually it's given in combination, and you can have a combination of two. You can still be having, like, let's say, for instance, you have a spinal for like a knee replacement. So that's a regional anesthetic technique, which is the third option, but they still might get some sedation on top of that. So then they would get MAC and regional anesthesia. But that's purely when we're talking about billing. For the general population, when we're talking about it, it basically comes down to either general, or you're getting sedation, or in very rare circumstances for an actual general anesthesia case, you'd be getting regional anesthesia only with no sedation.
So most of our folks are getting basically a general anesthetic.
They're getting a general anesthetic, and then they're usually getting a nerve block for post-op pain management after surgery.
So Clay, can you speak a little bit about nerve blocks? It's one of those things that when I started training, it wasn't something that was done a lot in the setting of breast reconstruction and deep flap reconstruction.
Sure.
But recently, obviously, that's become something that's more common. So can you speak to that, how it differs from an epidural and how that impacts whether a patient needs opioids to manage their pain after the procedure?
Sure. So for the longest time in surgery, surgeons have been using local anesthetics to inject around incisional areas, problem areas where they're doing surgery. And although that does have some effectiveness, if you think about your nervous system in terms of like a tree branch, you have a big root or trunk of a tree, and then it starts branches out into bigger branches, then smaller branches, all the way till you get down to twigs. So if you're injecting local anesthetic at a surgical site, meaning through an incision or somewhere around there, basically you're only affecting the twigs of the tree, thousands and thousands of nerves. And we have found out over time that you might have to make an absurd amount of injections to cover all the twigs that you need to cover, or you have to inject so much volume of local anesthetic to cover all those twigs that it becomes potentially unsafe for a patient, because we have max doses of that agent that we can give any one person based on their weight. So the whole idea behind nerve blocks and regional anesthesia was to go further back from the twigs and closer to the trunk of the tree and address the pain there, and then you don't have to go down and chase down all the twigs. And it becomes a more dense block as opposed to, say, traditionally just injecting local anesthesia at the surgical site.
So that's a nice way to think about it. We're basically blocking the tree trunk, not all the little branches.
Correct.
Kind of go right at the root cause of the problem.
Exactly.
And I agree with Dr. Kale that, a lot of our patients, I think they find in this no opioid system, they have a lot better pain control, but a lot less nausea. And that's probably the thing that we hear the most is the last time I had a surgery, I had terrible, terrible nausea. I woke up throwing up, and I haven't really seen that we've had that problem.
Sure. Yeah, opioids are a huge culprit in terms of the post-op anesthesia, nausea, vomiting scenario. And you hear it all the time. You have patients that come from another facility or have had surgery 10 years ago, and that's their biggest complaint, because honestly, that's pretty traumatic. If you have a big surgery and then after surgery, you're, hugging something, vomiting, that's not pleasant. And it's something very memorable, and the patient remembers that. They tend to lump it together. And I think that there's a lot of bad education that happens when that patient has that happen, that it's very easy for the recovery room nurses or their follow-up care to say, well, it's, this just happens under anesthesia, which, although that is true to some degree, I think bulking the nausea, vomiting just to anesthesia in general is probably a really bad way to look at it. And I think it has a lot to do with the opioids that we use in the operating room on standard cases.
Yeah, it's funny because for so long, we were taught that, pain is a fifth vital sign, and that meant opioid, generally speaking, things like Percocet, morphine derivatives, Dilaudid, were more or less mainstays for much of our training and even after training. But if this opioid epidemic has taught us anything, it's that there's a lot of ways to manage pain that don't involve, these terrible drugs.
Sure. And that's kind of the whole science behind the opioid-free anesthesia, is that, like you said, for the longest time, we were trained that pain was the fifth vital sign. We ended up basing our surveys and our reimbursement based off patient satisfaction scores. And the easiest way to not get a patient satisfaction score that's good is to let a patient be in pain. And we didn't really know what the best way was to treat that. So we ended up giving patients narcotics because they ended up leaving happier to some degree, but we didn't know what huge problem we were causing, and especially in our area. Like our local area, our tri-state area, West Virginia is the number one state for overdoses, and Ohio is number 4 out of the whole country. So we see it more so than anyone else. And if we can do anything to aid in preventing that or decreasing those numbers, I think we should do so.
So Clay, in your experience, having trained in an era where you used a lot of opioids to now where you're in a setting where you're trying to use opioid-free anesthesia, how do you feel patient satisfaction is now compared to back then?
Well, I think it's very different because we're still in the era where a lot of the patients that we are seeing for surgery now had surgery in both eras. And I think that patients do a lot better, and we get that. We always do our 24, 48-hour follow-up with patients, and they usually give really good reviews. And I'm not so sure if it's 100% related to their pain level at 48 hours after surgery, or if it's that they just feel better. They don't feel as groggy. They felt like they were up being proactive earlier. All those things are encompassing of the opioid-free anesthesia. And it's been known for a long time. If you can remember, a lot of belly cases that surgeons would do, they had this, what would we call an ERAS protocol, an early recovery from anesthesia protocol. And it was this big fancy thing, and all the general surgeons were using it for bowel cases because they thought the patients would do better, cause less bowel problems. Well, turns out a lot of it didn't really play much of a factor. It was mostly just limiting the amount of opioids that you were using. And they started using that in the 90s, and now it's definitely more widespread.
And we tried ERAS on our patients, and to be honest, the gabapentin in particular, patients really, really did not like it. And I think what we also found was it's more not using opioids.
Correct. Yeah, we actually had a recovery room nurse start with us when she was newer, and she hadn't did a lot of actual PACU recovery time or surgery recovery. She did more floor nursing. And I think early on, she was actually not too familiar with using Zofran, a very common antiemetic that we use in recovery room, because patients just weren't getting that nauseous, versus the recovery room nurses that came from other facilities. It was almost just like they already had it drawn up at the bedside when the patients came out because they assumed that patient was going to eventually get nauseated. So
how did you get involved with this no opioid anesthesia kind of technique? Because to be honest, we don't find a lot of anesthesia providers in the hospitals who are facile with this kind of stuff.
So very interesting story. It wasn't a goal of mine. When I ended up starting to do it, I noticed that I had a love for regional anesthesia, and I was doing a substantial amount of nerve blocks. And these were mostly orthopedic-based cases where nerve blocks are very prevalent. I would go back and I would have to audit our medication use for the month. And I would find out that in 1 month's time, I was giving maybe 4 or 5 doses of narcotic in a month. And I was just sitting there, I was like, why do I even need it at all? If I'm only using such a small amount, obviously there's a better way. So then I started researching the different medications that we would use to complete truly opioid-free anesthetic, started playing around with them in the OR, and really liked what I saw. It made me not have to use blood pressure medicines nearly as often, both if they have high blood pressure or low blood pressure. The patients were up and moving a lot quicker after surgery. And so I became a big interest in it then. And then when I converted over and came to you guys, when you guys opened the center, it was a solely outpatient facility. And I knew that if we were going to have whatever volume of patients we were going to have that was busy, that it was going to be key to have patients that could get up, feel better, and get out the door quicker. At the hospital, they don't have that much motivation because if the patient is ready to go home, they go home. If not, then they can admit them to the floor or wherever. And it just seems like they're not super motivated because it doesn't usually affect them on the back end. Versus if I have a patient that has to stick around for 8 hours after surgery, well, that messes up the whole flow of the operating room sometimes. Not that we don't have avenues to address that and be, accompanying of a patient that needs to stay, but it's so rare that getting them out the door feeling better quicker is obviously good in any situation.
Now, we've noticed that
Clay?
with the microsurgical cases that we've done, that not only are the patients going home the next day, but they are feeling better. They have a much better experience, better pain control, less nausea. And so by virtue of this type of protocol, we're able to do more complicated cases with better outcomes, I think.
Sure.
But Santosh, you had a comment?
Yeah. No, I think that's a really important point that you made, Pankaj, that we're able to do cases now that traditionally would have been kept in the hospital longer, and especially given everything that's going on with this pandemic, I think it's really important to note that we're able to do cases and get people out earlier. But, since we've been spending a lot of time on opioids, Clay, do you find that there's really any role for opioids anymore in anesthesia?
Yeah, I think so. I think that the first comment on that would be patients that are already on very large volumes of narcotics when they come in. You never want to create a basically withdrawal situation. If a patient comes in and they're on a lot of narcotics baseline, and we do, as you know, at the center, we do a lot of spine cases, and sometimes those patients are in horrendous amount of chronic pain and they're on pain medicine. So withholding pain medicines from people like that could cause a whole different non-surgical issue with withdrawal and different things like that. But for the 2 hours or so that they're in the operating room, do they need the narcotics? Almost never, even the patients that do come in on a lot. And it's just because of the science behind the medicines that we use today. And then as far as post-operatively, sure, if a patient comes out and we have their pain down to a 2 or a 3, pain is very, subjective. My 2 or 3 might not be the same as your 2 or 3. So patients are usually, when they're awake, alert, and can make a cognitive decision when they're home to take a pain medicine or not to take a pain medicine, we do put that onto them. And a lot of the times they make the right decision. But if we're giving them obscene amount of narcotics before they're even conscious enough to make that decision on their own, then we're kind of making that decision for them. And I think that's where some of the issues lie on giving intraoperative opioid, let alone it's been a very well-documented phenomenon that opioids can cause a hyperalgesia when they're wearing off, meaning somebody that comes in that's not used to having pain medicine at all, and they're asleep, and you're giving pain medicine during the case, and then the pain medicine is wearing off the same time that the patient's waking up, it actually can cause a increased pain sensation than it would have been if they didn't have the narcotics in the first place. And I know anesthesia providers that can do a beautiful anesthetic with narcotics. I think it can be provider choice, but I think more so than being provider choice, it should be patient focused. And if a patient has the option to do a surgery without narcotics and have a better recovery, I think we should do everything we can to give them that option.
So we're also in an era where patients are very well educated before they even come into the office, hospital, clinic. So do you think patients should be asking for opioid-free anesthesia? Should they be asking their providers for this?
I do think that they should. I think starting a demand for it would force people into doing some more education to come up with, the current times and how we're doing anesthesia. With that being said, I do worry that if you push a anesthesia provider into something that they're either not familiar with or not comfortable with, that may potentially lead you with a worse situation than it would have been if you just got the narcotics. But I think that comes to providers and, being willing to learn the new data and the new ways to do things. But you don't really want somebody experimenting on you unless, they have the resources available to kind of figure that kind of stuff out. And at minimum, it wouldn't have to be maybe to start out. And that's kind of how mine started out, is I didn't quit cold turkey and go an opioid-free anesthesia. It started out as an opioid-sparing anesthesia, then converted finally to opioid-free. And May was 2 years that I haven't given narcotic in the anesthesia world. So,
yeah, it's fascinating. I think that point you made, Santosh, about the educated patient. Clay knows we had a lady a few weeks ago who had come in, very educated patient, and she wants no opioids. She doesn't want to be intubated. And we are doing a case that we would normally give her general anesthesia for. And Clay and I discussed a combination of a chest block and a lower extremity or epidural block. So that's another thing that I find isn't really done in the hospitals is blocks. Maybe talk to patients or people listening about what is a block, how does it work? We talked a little about the root and tree concept, but how do you use the ultrasound? How do you find the exact areas to block?
Sure. So nerve blocks have been around for quite some time. Historically, they were used in more orthopedic type cases where a lot of the nerves that you were going to target were both motor and sensory, meaning that same nerve that supplies sensation to saying, ow, that hurts if you touch me here, is the same nerve that is telling that muscle to fire in, say, contractor bicep. So we were doing those with no ultrasound and purely based on just anatomical structure and using what we call a nerve stimulator, and you actually dial it in and it sends an electrical current to that nerve, and when that nerve fires, it sends a specific muscular response. For instance, if you're doing what we call would be an interscaling block here, right where the neck and the shoulder meet, you would turn that nerve stimulator on and you would see certain movements in the arm or flexing of the wrist, and that would tell you what nerves you're targeting. And although that was obviously effective, it's fairly dangerous because you weren't seeing all the very important structures that you were working on or around, meaning blood vessels, lung, different things like that. With the use of the ultrasound, people had put off using it for, seemed like forever because it's very complex. The ultrasound, I mean, people go to 4-year degrees just to learn how to navigate an ultrasound machine and diagnose specific things, or just to even image it just to send to a radiologist for diagnosis. So once people finally started branching out and learning the ultrasound and the complex nature of it, they realized how much better it was. You ended up seeing all the structures that you wanted to see. You could avoid the ones that you didn't want to see, and et cetera. As far as the breast cases go, we typically do a series of 1 or 2 blocks depending on if there's muscle involvement in the breast case. If there's muscle involvement, I would say there's probably a 70% chance that they might have the series of 2 nerve blocks to supply both all the sensory component of the skin, nipple, mammary cells, little baby blood vessels, little baby nerves. But then if there's muscle involvement, the muscle is supplied by a separate nerve that comes down this way, and we have to tag that one separately. As far as the method of action of how the blocks work is we just use local anesthetic that's been around forever, and we, instead of injecting it close to a nerve, we actually get right up against the nerve. We inject that local anesthetic into the nerve or around the nerve, and that speeds up the onset to where that block can work in as little as 15 minutes or maybe in some cases the same minute that you do it. And then that medicine where it stays localized around that nerve can last for 24, 48 hours before your body absorbs it and it's metabolized.
Yeah,
Clay, so a lot of our patients have had epidurals before in the past.
Sure.
Can you tell us, and sometimes there's a little confusion regarding some of the blocks that we do for breast surgery. Can you tell us how that differs from the blocks that we do for breast surgery from an epidural?
Sure. So an epidural, both an epidural and a spinal, are working at the spinal cord level of your nervous system. And actually, if you would think back to the tree analogy, it would be more underground where the roots were versus where the trunk is. And what we're doing is we're actually targeting, at any given point on your spinal cord, you have off the backside of, if you're looking at a cross section, say this is the backside and this is the bottom side or the front side, the nerves that supply sensation all come off this dorsal rami that we call, and then everything that supplies motor comes off this anterior part. When you do a spine or an epidural, it's going to affect both. because it's a dense blockade within this and it's supplying both sensory and motor. So if somebody that's came in that's had an epidural or a spinal, they knew, hey, I was numb, but also I couldn't move anything. Couldn't move my legs, couldn't feel my belly, couldn't do any of that. With this, because we're not attacking any part of this anterior chain that supplies motor, we're selectively choosing the area that supplies sensation. So we're able to get a block that supplies block of sensation, but does not affect the motor aspect of those areas. So that's, if that answers your question.
So would you say epidural is maybe closer to the actual spinal cord and some of the nerve blocks we do are further away?
Correct. So an epidural or a spinal are midline on the spine. You find right where the midline of the spine is, and you go directly at it when you're doing a spinal or an epidural. We actually, under ultrasound guidance, slide over to where the transverse process of the vertebrae is, and we actually inject there. So you're several centimeters removed from midline of the spine.
Yeah, the thing that I've seen most significantly in our patients is once the block is worn off, let's say that's 24, 48 hours afterwards, they're almost uniformly just on Tylenol, ibuprofen. I mean, we'll give patients a prescription for something a little bit stronger, but it's really amazing how we've transitioned not only off opioids in the immediate postoperative time period, but for the long term. I mean, it's really unusual for patients to be taking Percocet or any of those types of medications now, even 3, 4, 5 days after the operation.
Sure. It's no secret that first 24 hours after a surgery procedure would be the most painful. And that's kind of the goal of these blocks, would be that if we can get them past the 24-hour mark, then that's kind of, onto the promised land, I guess, in terms of recovery, getting them past that 24 hours. Now, there are certain things that we do playing around with the concentration of the medicines and different additives in the medication that we give to sometimes make it last longer, or in rare circumstances, if you need it to not last long, we can use different medications to make it work really quickly, but it doesn't last long. And in terms of our breast cases, that would be pretty rare that you would need one to work quick and not last long. Most of ours is for post-op pain management, so we want it to last as long as possible.
Where do you think this type of protocol is going in the next, 3, 5, 10 years? Like, where are we headed from a pain control perspective? Because already this has been a paradigm shift compared to where we were 5 years ago.
Sure. There's already facilities across the United States that are going completely opioid-free. That's no new thing. There's already facilities that have been pushing it for quite a while, and I think some that are already successful in doing so for a couple of years. And there's legislation. We hosted a House representative for the state of Ohio at our center, if you recall, and she came to shadow and see us in the operating room because she was actually promoting a bill that would allow patients to have access to opioid-free anesthesia or opioid-free surgery or opioid-free options when they come into the hospital, whether that be if they are in the ER for pain or they're coming in for surgery and they're going to have pain. And the reason that those kind of bills exist is because of the opioid pandemic. The epidemic. There's, I think, since 1999, we're coming up on almost 1 million deaths due to overdose. And 70% of those are prescription-based drugs. It's not like they're getting some, street drug from Mexico. It's prescription drugs that are causing 70% of those almost 1 million deaths since 1999. So these politicians that essentially have no medical background, they don't understand all of the stuff in between, but they can identify, hey, there's a problem, and hey, we need to at least poke in the dark to come up with a solution, or we're going to have quite a situation on our hands. So with the difference in them pushing legislation to give opioid-free options, so many facilities already doing it and having a lot of success, and me personally doing it, not thinking that I would end up being the opioid-free anesthesia guy, but seeing how well my patients do, I think if anybody else gets to see that or witness it or experience it, I think it's pretty obvious that they're going to continue to do that. And when I hire other anesthesia providers to come into my center, I give all of them the option of trying the opioid-free anesthesia with me and seeing if they like it. And 100% of them love it. And they say that after they leave, that they'll continue to do it even after they leave. So sometimes these are very seasoned anesthesia providers that have been doing it for 30 years. So you know, and I guess you can teach, you know, an old dog new tricks in terms of the different anesthetic techniques, especially if you make it easy. If you make it complicated, then people are less apt to learn new things. So I think keeping it simple is a big key.
Clay, you had mentioned earlier about certain types of medicines that you inject around the nerves. What's this stuff called Exparel? It's been around for a couple of years. What are your thoughts on it?
So we have used Exparel in the past. At face value, I like it. I like it a lot. But when I have to look at the cost of medications and, you know, different patient outcomes, it is a better drug, but it is a substantially more expensive drug than what we use. And this is kind of a complex topic that I don't know if a lot of people understand or know about. But when we use these local anesthetics for nerve blocks, there's a difference in terms of the length of anesthesia that they get with the block, meaning they're numb, they don't feel anything. And then there's a difference in time of analgesia. So a lot of the blocks that we do with ropivacaine, lidocaine, marcaine, the typical local anesthetics that we're used to seeing in the operating room, those have a shorter anesthetic length duration compared to Exparel. Meaning, so let's say if I use ropivacaine, that it might last for 18 hours of anesthesia. But then for analgesia, meaning that although the patient's not numb anymore, they're not hurting, might extend into the 24-hour to 30-hour mark. Versus with the Exparel, what I see with that is that anesthesia is longer, meaning the patient's numb longer, but the difference between the amount of time that they're numb and the time amount that they start having pain or the analgesia part goes away is much smaller. So it lasts longer to keep them numb, but once the numbness wears off, they're back to pain in some degree fairly quickly, versus the other one seem that the numbness wears off and then the pain relief part of it might last substantially longer. But that's some new information. I don't know if there's a significant amount of studies that are being done on that, but that's just what I see clinically when we would call and do our follow-up with our patients at our center.
Yeah, I think it would be great to have like other anesthesia providers come by Onyx and see your protocol, because I think it would be such an eye-opener. I always mention it to people in the hospitals, and I think there's a little bit of reluctance to, you know, modify their techniques or even to believe, quite frankly, that this works as well as it does.
Sure. Yeah, when you talk to other people, you get almost like a kind of like a vibe of it's complicated, it's expensive, they try to find excuses, I guess is what it boils down to, is they find excuses to justify how this works differently or how this works better. I think that for every talking point that you could figure out, there's always a situation where you could explain how opioid-free anesthesia does better. And I think the idea that a lot of people, when they first start learning about it, think that it's complicated, they don't even take the first step in doing it. There's very easy ways to simplify it, and I think just about anybody can do it. And that's, like I said, when people come to our center, that's what I teach them, how I do it. And they're like, oh, that's it? I'm like, yeah, that's it. And they're like, well, I could do that. But if you're just reading it in a textbook or on a forum, you're like, whoa, that's a bunch of different drugs at a bunch of different rates, and how do I do that? And it's kind of overwhelming. So I think simplifying it goes a long way for sure.
So Clay, besides some of the things that we have talked about, what should patients look for and ask for as they are deciding to have breast-related surgeries?
So there have been studies done clear back since the 90s in terms of breast cancer reoccurrence rates. And a lot of those were just kind of searching for a rationale, a reason, a cause. There seems to be, at minimum, some debate if opioids cause issues with breast cancer recurrence, because it's pretty known phenomenon that opioids can inhibit a cell-mediated immunity of sorts. And if that's the case, then it doesn't really matter what the cancer is. It could cause issues with replication and different things like that. So they do see lower rates of reoccurrence in opioid-free anesthetics or opioid-sparing anesthetics as opposed to the opposite, which is interesting. But a lot of the studies are having a hard time actually targeting if that's true, false, or whatever. There's so many other confounding variables in any one person's medical history to target that down. But if you do look online, there's a substantial amount of research on if opioids do cause some issues with breast cancer reoccurrence. So in terms of breast cases, I would say that that's one big option to look at is, if obviously you're having the surgery to deal with a breast cancer, the last thing you'd want to do is to have that reoccur. But then also what patients want to do as far as post-op care. Some people are scared of the idea of needles or what would technically be extra procedures. I get that, and I completely honor their concern with that. But if the issue is, hey, I don't do well with pain medicine, then I really think anesthesia providers should be attentive to that and offer the patient some different options as far as not giving them those pain medicines if it's giving them track record of issues in the past.
What do you hear from patients, as their most common fears? When you're talking to them in the pre-op area, what is the thing or the couple statements that kind of ring true and most commonly with you?
The first thing is I think they've maybe read or have done some research about the nerve blocks previously, but just that, hey, either they work or they don't, or the patients like them or they don't. But as far as what the actual procedure of doing the block is, I don't think that they've looked into very much. And one of the most common questions that we get from patients is, well, one, is it going to hurt? And two is, well, why can't you do this while I'm back in the operating room? Like while I'm still under general anesthesia, essentially. And that's a complicated question because, yes, we choose to do it when they're waking up from anesthesia, usually when they're still in that kind of what we'd consider a loopy phase, enough to where they could probably sit up on the side of the bed and at least acknowledge if they're hurting or where they're hurting, because we're really bad at guessing. Every patient's different. I have a pretty good idea of where a patient's going to be hurting exactly after a surgery, but until that patient comes out of surgery and says, hey, I hurt here versus here, it goes back to that conversation that we had about local anesthetics. There's a max dose of local anesthetic that any one person can get based on their weight. And if I decide, you know what, with this surgery that you're going to have, even though we haven't done it yet, I'm going to assume that you're going to hurt here. So I'm going to target those nerves now. And then you wake up in a recovery room and you're like, I actually hurt here. And now I've used all my local anesthetic. So now I'm at my ceiling of where I can go with my local anesthetic. So instead of guessing ahead in pre-op and doing the blocks then, we could put ourselves in a situation where we essentially gave you a nerve block, but now you're still going to be hurting in recovery room. The other situation is patients that have had complex breast surgery in the past. Let's say that this is their third reconstruction. Those nerves aren't going to be supplying all the same areas and following the same paths as somebody that's never had breast cancer. So one lady with breast cancer may hurt here after an identical surgery versus this lady might hurt in a different place. So, or they might be so numb from the mastectomy that they might not have pain at all. Although I find that to be rare, it does happen. And if they wake up and they feel perfectly fine, I'm not going to put them through another procedure that they don't need. I'm only going to give them things that are going to help them and benefit them. And if they're not having any pain, giving them another block or whatever is not going to help them in ways.
Santosh, do you have a comment?
No, I'm all commented out.
Yeah. I mean, I think probably the best thing about this conversation, I always learn a ton when we have people on the podcast that are experts in their field, and Clay is certainly an expert in his field, because a lot of this stuff is hard for us to explain to patients because we don't fully understand it. So the question of, what type of anesthetic am I getting? I oftentimes tell people an inhalational anesthetic, it'll be a general anesthesia. but it's not going to be quite the level of sedation as some of the operations we do in the hospital. Do you think that's a fair way to explain it to people, Clay?
Well, I try to tell all the patients the same thing when they get there, when they have the same questions that you just asked, is if it is going to be a general anesthesia, I tell them that there's going to be an airway inserted. Now, airways can be very different. We have two different airways that we use mainly in anesthesia. One is what we call an endotracheal tube, which it's a tube that actually goes through your trachea, and it has a balloon on it that we blow up, and then that seals off your vocal cords so nothing can pass from your stomach to your lungs or vice versa. The other option that we have is a device called a LMA, or a laryngeal mask airway. And basically all it is a fancy rubber airway that just sits behind the patient's tongue and allows them to breathe on their own during the case. Because when you're under the amount of sedation that you would need to have general anesthesia, everything in your airway relaxes, and the LMA does a good job of keeping everything up to where it needs to be so you can breathe on your own. So I think general anesthesia is a good way to put it, but probably what the patient's really looking for when they ask that question is, are they going to have an airway or not? And in most cases in breast surgery, the answer is going to be that they will have some form of an airway. And that's because we work in such close proximity to vital organs, lungs, etc. And depending on the muscle involvement, if we need paralysis or not, it's a pretty safe bet that a patient that's having breast reconstruction will have some form of an airway, which would fall under the category of general anesthesia.
Well, I mean, I think this has been amazing. I think this has been a ton of kind of real high-level anesthesia information, and I know I've certainly learned more than I knew coming into this, so thank you, Clay, for continuing to be such a patient advocate and for helping us figure out ways to do these operations in people and do it in a way that the pain's well controlled, that our outcomes are great, our recoveries are great, and I think one reason why I think patients like coming to the center as much as they do because of the great anesthesia care that they get. Frankly, probably the best anesthesia care that I've ever had for any of my patients. So any final thoughts here, Santosh?
I think this conversation has been great because it gives patients the education that they need in a world that's just rapidly changing. And it allows patients to kind of take some of their care into their own hands within obviously a certain degree, but also allows them to have a level of education that, as you had said before, I learned a lot just from this 45 minutes in talking with Clay. So thank you.
Yeah, I think, being at a type of center that we are, the smaller and more individualized things are, we have patients that have questions. And what do? We get them in contact with me or one of my colleagues, and we talk with them directly. We answer all their questions. We try to adjust a game plan that's going to fit their needs best. And it is substantially more difficult to get that done at a bigger facility because there's so many moving parts. You don't know who's going to be working on what days. So the more that we can do to make things more individualized for the patients, they're always going to have a better experience, in my opinion.
Well, there you have it. A complete overview of anesthesia for our patients at Onyx and Pearl. Please tune in to our episodes. They drop every Wednesday. And thanks for listening to the Best Podcast Ever. Thanks, guys.
Hey, thanks for having me.
Thank you.
Thanks for listening.
We hope you found this episode helpful.
Want more info? Connect with us at mwbreast.com.
And go behind the scenes with us on Instagram at mwbreast. Thanks for tuning in.
And join us next week.